The next presentation in the mini-series will focus on hyperthyroidism. Thyrotoxicosis is essentially the condition of having too much thyroid hormone in the body, or hyperthyroidism. This results in tissues being exposed to excess levels of T4, T3, or both hormones. Patients who present with hyperthyroidism are going to be showing signs and symptoms of overactive metabolism. These can be seen as increased appetite, weight loss, heat intolerance, anxiety, heart palpitations, or a goiter. A goiter is essentially an enlarged thyroid gland where the lobes are enlarged beyond the normal border. This creates a bulge at the base of the neck. Goiters can result from hyper or hypothyroidism. It was most commonly associated with iodine deficiency, which we learned in the hypothyroidism is a major cause of hypothyroidism around the world. Now it's more commonly associated with Hashimoto's thyroidosis and Graves' disease. As you can see, there are many different reasons that patients can have hyperthyroidism. The most common is Graves' disease. This is generally seen in females ages 20 to 40 years old. It's an immune etiology where antibodies stimulate the thyroid via the TSH receptors, resulting in excess T3 and T4 production. Other sources of hyperthyroidism are toxic nodular goiter, toxic adenoma, thyroiditis, drug-induced hyperthyroidism, or pituitary tumors. Drugs are one source of hyperthyroidism and can do so by many different mechanisms of actions. Drugs with high protein binding can displace T4 and T3 from albumin and proteins in the blood. This results in higher free T4 and T3 levels in the serum and therefore creates an effective hyperthyroidism. Medications that we think of causing this can be phenytoin and carbamazepine. Amiodarone can cause hyperthyroidism because it contains iodine atoms. It can also block the conversion of T4 to T3. Medications like levothyroxine can obviously cause hyperthyroidism because if we were to oversupplement a patient. Iodine, and lastly, interferons can affect antibodies and cause the immune forms of hyperthyroidism. When it comes to treating hyperthyroidism, patients have three main options: medications, including THIOAMIDES, radioactive iodine, or RAI, and surgery. Thioamides are a class of medications that are used to treat hyperthyroidism. They work by blocking the processing of iodine in the thyroid and therefore inhibits the synthesis of thyroid hormones. Monitoring needed for these medications include baseline liver function tests, CBCs with differentials, and looking for signs and symptoms of hypo and hyperthyroid. The two drugs that are in this class that we would see used are PROPYLTHIOURACIL and METHIMAZOLE. PROPYLTHIOURACIL, or PTU, is the first medication in this class. Along with blocking the incorporation of iodine in the thyroid hormones within the thyroid gland, it additionally inhibits the peripheral conversion of T4 to T3. This medication is initially dosed at 300 to 600 milligrams a day, divided in 3 divided doses. The maintenance dose is 50 to 300 milligrams per day, divided 2 to 3 times daily. If a patient presents with a thyroid storm, then you would give them a 600 milligram load and then 200 to 300 milligrams every 6 hours. This drug is preferred in thyroid storm because it also prevents the conversion of T4 to T3 in the peripheral tissue, and this will prevent the hormonal activity throughout the body. A thyroid storm is essentially decompensated hyperthyroidism. It's an acute, life-threatening hypermetabolic state. Patients may present with fever, tachycardia, dehydration, profuse sweating, agitation, delirium, psychosis, or coma. Other dosing strategies do exist besides the ones on the slide, but it does depend on the severity of symptoms. Some potential adverse reactions with PTU include fever, rash, arthralgias, GI intolerance, leukopenia, hepatotoxicity, and agranulocytosis. Methimazole is the second thioamide that's used to treat hyperthyroidism. It's very similar to PTU, except it does not block the conversion of T4 to T3, and therefore we don't want to use this in the case of a thyroid storm. It's 10 times more potent than PTU. The dosing here, with the initial dosing, you would give 30 to 60 milligrams per day divided in 3 doses. The maintenance dose is anywhere from 5 to 30 milligrams a day once the patient is euthyroid. Adverse reactions are similar to PTU. The second type of treatment that we could give our patients with hyperthyroidism are iodides. These are a temporary solution and are not used long term for treatment. We rarely see them as adjunct, but they do temporarily block iodine organification and therefore inhibits the secretion of thyroid hormones. Potassium iodine, or saturated solution Ki, SSKI, comes in a formulation of 30 milligrams a drop, and the Lugol solution comes in a formulation of 6.3 milligrams a drop. The place in therapy for this medication is the management of acute thyrotoxicosis. You can also use it in preparation for a thyroidectomy, and then it can also follow radioactive iodine therapy. Dosing for these iodides depends on the formulation. For the SSKI, patients will receive 1 to 5 drops a day, or 3 to 5 drops a day for the Lugol's formulation. This is put in water or juice 3 times daily for 7 to 14 days prior to procedure. It can also be used as an adjunct to the radioactive iodine therapy. If this is the case, you would use for 3 to 7 days after treatment so the radioactive iodine can concentrate in the thyroid. Some toxic effects that are possible with iodides are hypersensitivity reactions, salivary gland swelling, iodism, and gynecomastia. Radioactive iodine is another treatment for hyperthyroidism. Um, it's first line therapy for definitive treatment because it's cheaper and has fewer complications as compared to surgery. The major reason we would not want to use this is if a patient is pregnant or breastfeeding. If a patient has severe symptoms, we would treat with PTU and propranolol first. If there are mild to moderate hyperthyroid symptoms, then we may want to proceed with radioactive iodine without first treating with PTU and propranolol. Iodine 131 specifically disrupts the synthesis of hormones and destroys thyroid cells. Again, its place in therapy are patients who would be poor surgical candidates, patients who have recurrence after surgery, or patients who have failed thioamide therapy. Just to recap, for which patients is surgery the best treatment option in the case of hyperthyroidism? Patients who would benefit from surgery include patients with extremely large goiters and patients refusing first-line treatment, which is radioactive iodine. As stated on the previous slides, another option for treating hyperthyroidism is surgery. Oftentimes, we have to give medications preoperatively in order to prepare the thyroid gland for surgical removal. Pre-op, you may see patients getting methimazole or PTU 6 to 8 weeks prior to surgery. They may also be getting SSKI in conjunction with that 7 to 14 days prior to surgery. Beta blockers are often used for symptom control. And postoperatively, once the thyroid gland is removed, we have to replace the thyroid hormone, oftentimes with a levothyroxine. As stated before, beta blockade can be very helpful in helping control patients' symptoms from hyperthyroidism. Symptoms that can benefit from beta blockade are heart palpitations, tremors, and anxiety. Propranolol is a good agent to start with, and the starting dose is 20 to 40 milligrams orally 4 times daily. Patients may end up needing up to 240 to 480 milligrams per day. The goal heart rate is generally less than 90 beats per minute.